already resolving at that point. And by cycle 4, when we repeated the scan, he had a very nice partial response, and he had 7.5 months of PFS in a disease that, as I say, normally doesn't respond to chemotherapy. You expect to see a PFS of 1.5 months if you did a scan at 6 weeks, yet this patient had a quadrupling of his PFS. This is another patient who was borderline PS1 when he went on the study. A very large amount of disease burden from the sarcomatoid mesothelioma. You can see the large masses in the chest and big pleural effusion. He also had bilateral adrenal metastases and some kidney metastases. And he also had, his main symptom was actually fatigue, and he had more than 10% weight loss. He had stable disease for best part of 6 months following treatment with ADR, with a minor reduction you can see in these tumour masses. The pleural effusions responded to treatment. So in the MTD expansion cohort, again, same sort of side effects that we've seen before, mainly skin rashes that's been described with monotherapy, and generally the treatment has been very well tolerated. We have had to dose delay occasionally due to problems with blood counts such as thrombocytopenia, but generally very well tolerated regimen. And in terms of what we've seen before in previous presentations, again, there seems to be a longer period of arginine deprivation when using the triplet combination. So in the monotherapy arginine Adam study with ADI, we saw the arginine levels basically come back to baseline by around 8 weeks or so. Here you can see they're actually suppressed for much longer, and similarly citrulline levels remain upregulated for a longer period of time, suggesting that perhaps with the steroids or the combination chemotherapy, you're actually modulating the anti-ADI-PIK20 response. And again, if we just look at the mesothelioma patients on the study as shown here in the response data, exceedingly high disease control rate. In this study, where 2/3 of the patients enrolled had the biphasic sarcomatoid tumours, we've had 2 PRs with sarcomatoid meso, and we've also had a lot of disease control, stable disease ongoing for several months in these patients that normally you wouldn't expect to respond to doublet chemotherapy. This is another patient with sarcomatoid mesothelioma. Again, he presented with weight loss, chest pain, and sweat. And you can see a very nice response. And he's actually, as far as I know, currently alive, and we've referred him back to his referring centre. He subsequently progressed and had second-line chemotherapy. He also had radiotherapy to the mediastinum for impending severe vena cava obstruction, but has done really very well on the study, had a very nice partial response. So overall, if we look at the overall PFS, again, we're seeing in the sarcomatoid and biphasic a doubling to a tripling of the PFS in this group. The OS data is immature, but as I mentioned, in the UK at least, the median OS is around 4 months in this patient group, and at the moment we're seeing OSs of 6 to 7 months in this patient population, and an overall very high disease control. And one patient progressed but actually couldn't tolerate treatment very well, and that probably was significant for the 3% loss in disease control. Again, if you look at the spider plots, prolonged control of disease in the mesothelioma cohorts, and this is the non-epithelial cohort, again, much longer than you would expect normally. So one of the problems with resistance to ADI-PIK20, as we've heard, is neutralizing antibody response, but the other one that is well described in preclinical, less so in clinical, and this is the first biopsy of a patient to show this, who subsequently progressed after about 4 months of PFS on the study, is in very strong, robust reduction of ASS1, and this is really a very likely scenario, I think. We just don't have enough pre- and post-treatment biopsies to show this. This probably explains why he subsequently progressed on therapy and had a very nice, almost partial response and disease control, having presented again with night sweats and quite a lot of symptoms. We also looked at FLT PET. So you may remember I showed the preclinical animal model. After one dose of ADI-PEG20, reduction in FLT uptake. So we wanted to look at this in the human subjects on the study, and we looked at 4 time points. We did a baseline FLT PET, one at around 24 hours following ADI, but before addition of pemetrexed and cisplatin, one again at day 15, and then one at the end of treatment to see whether we could see any early evidence of modulation of FLT uptake. And we have seen some early responses, around 20% of patients at the 24-hour imaging time point. And you can see in some of these cases where a patient would have stable disease by modified RECIST, we actually saw responses by FLT PETs. The tumour may appear stable on the CT scan, but actually by metabolic imaging, there's a very nice partial metabolic response. This is an example of a patient with mesothelioma who had an 11% reduction here in the mediastinal part that was active by FLT PET. And this is a patient who had a non-small cell adenocarcinoma of the lung, who had a 25% reduction in SUV, and we presented this as a poster at ASCO this year. So again, providing evidence that ADI-PEG20 is modulating salvage of thymidine very early on with treatment. So this leads on to the rationale for the next study. Because of the encouraging data, particularly in the aggressive patients who normally, as I mentioned, wouldn't respond very well to treatment or not at all. This study, the Atomic Meso study, will be a phase 2/3 ADI PEMSIS triplet versus PEMSIS placebo. We'll only be looking at the patients with the aggressive mesotheliomas. Patients will need to have ASS1 loss, be fit for a PS. Usually these patients are going to be symptomatic, but fit to go on to the trial. Will be a multi-center global study with a primary endpoint for the phase 2 component of overall response rate, and then proceeding to a phase 3 PFS and possibly OS is the primary endpoint for the phase 3. So looking at the overall response rate data in TRAP, we say nearly 60 patients now have been treated. In addition to the mesothelioma and the non-small cell lung cancer cohort, we also have patients with uveal melanoma, which is a very intractable melanoma where the current immunotherapeutic revolution has unfortunately made very little impact in those patients, and there is still no approved treatment for uveal melanoma. We've also got a 10-patient expansion cohort in patients with GBM, and there's also a study exclusive to Taiwan looking at HCC. I'm not presenting that data here, but the important message here is, these are all aggressive cancers, and you can see that there's a very high level of disease control rate. Some of the patients that have progressed there, I think one was the epithelioid meso patient that didn't tolerate treatment, and some of these are the uveal melanoma. But we do have some patients ongoing 7 months plus now with uveal melanoma, which speaks again to the fact that this is an active regimen when you start recruiting patients who you wouldn't expect to come back to clinic again after 2 months because of disease progression and still being treated with the trial treatment. So this is the data in the non-small cell lung cancer, which has actually been quite hard to recruit these patients because, again, these patients turn out to be quite symptomatic, have issues with pain, breathlessness, often complications of their cancer. So again, the remarkable thing is that these patients are actually responding and have a 50% or so partial response rate. But you can see, unlike the mesothelioma, that these patients, despite having early on having had a partial response, are actually progressing quite quickly. And I think again that speaks to the fact that we're selecting out patients with aggressive biology, probably ASS1 is being induced. We are about to open a further part 2 track where we'll be doing repeat biopsies of these patients on progression to look at this in more detail. So in the uveal melanoma, as I mentioned, this was a small cohort of 10 patients. In fact, the last patient we should be recruiting, patient number 10 next week. And I think somebody who basically puts a new patient on every week with metastatic uveal melanoma on some form of treatment, this to me tells me that there is definitely some efficacy in some of these patients. I have one patient who's now 7 months on ABI Pembrolizumab. He's now on maintenance ABI. He failed ipilimumab, failed pembrolizumab, which is the known situation with uveal melanoma. And yet he's got a very good quality of life. He comes in weekly for his ABI-20 and says he's never felt better. He's now 2 years with metastatic disease in the liver. So I'd be very interested in looking at this further in track.